from me is that there will be feedback questionnaires after the session. We'd love to hear your thoughts. You know, at the moment, this is the last session we have planned, so keen to hear your thoughts about what else you'd like to hear about, as much as your thoughts about the session today. There are certificates that are attached to those feedback questionnaires, so once completed, you can have those for your CPDs and your portfolios. So without any further ado, I'd like to hand over to Dr. Leema Robert, who is our first speaker. Leema is a clinical geneticist based at Guy's and St Thomas's Hospital, who runs our aortopathy service there. And Leema is kindly going to speak to us about inherited aortopathy in general and give us an overview of the conditions. So thank you, Leema. We can see your slides. Yes, you just may want to switch that display settings. Perfect. I'll hand over to you. Thank you very much, Leema.
Hi, everyone. So I think you can see my slides now. Thank you, Rachel, for the introduction. I'm a clinical geneticist working mainly in cardiovascular genetics at Guy's and St Thomas's. And so today I'm going to introduce inherited aortopathies to you. So when you hear of inherited aortopathies, what do you think of? So if I ask ChatGPT, that's what it says. And I actually think quite a lot of people will probably think about, oh, that's Marfan syndrome, isn't it? Oh, because it's inherited, it probably runs in families and there's a risk for my children. I don't know if many people think whether that it is actually young onset and it's actually associated with a risk of sudden cardiac death as well. But those are things that probably do pop up in your mind. And in a way, you're all correct. Inherited means it runs in families with a risk to children. And aortopathy is basically describing that there is something wrong with the aortic disease, essentially. And what we are talking about mainly is thoracic aortic disease. So aortic dilatation, and these are the definitions for them, and these are the different types of aortic dilatation. But the main thing to remember is this is completely asymptomatic. So we are not going to get patients who are coming to us feeling unwell. Unless we go look for it, we are not going to find it. Aortic dissection, on the other hand, is something that people will actually present with, and it's often quite an acute event and highly lethal. And again, there are the different types of aortic dissection depicted in the pictures there. So if we take a scale kind of saying from birth to around 80 years, older onset disease is often wear and tear, and it's actually of degenerative etiology. But if it's younger onset, then it is unusual. And then what we then kind of consider is, are there any other unusual features present in these individuals, in which case it could be syndromic? If there are no unusual features, but there are several family members affected, then we also raise the question, is this familial? If we think about what are the risk factors, this is a publication from quite a while ago, more than 10 years, to be honest. As you can see, the aortic, abdominal aortic aneurysms, which is in the short form of AAA, aortic dissection, and thoracic aortic aneurysms. Smoking and lipids probably contribute to quite a bit of abdominal aortic aneurysms, and the NHS screening offers for individuals more than age of 65 abdominal aortic screening, and this is more prevalent in men, and therefore it's offered to them. Aortic dissection, again, the risk factors, you do have hypertension, smoking, and lipids. But when we come to thoracic aortic aneurysm, although smoking does play an attributed risk, there are other factors that are not very clear, and genetic factors are perhaps behind those as well. The other aspect of thoracic aortic disease is that if we go screen family members, in around 20 to 30% of cases, we would actually find another affected first-degree relative. Therefore, screening family members is actually really important to identify who else in the family has symptoms as well, especially, as I said before, a dilated aorta is not symptomatic. So when we come to the genetics of this condition, there are three main kind of groups of genes that we focus on. The extracellular matrix genes, which is usually the genes associated with Marfan syndrome and vascular EDS. And then we have the TGF-beta vasculopathies. And then you have the smooth muscle cell contractile vasculopathies as well. And essentially, there are several genes involved in all these groups, and I'll just go through them briefly for a bit of an overview. So when we're talking about the extracellular matrix, when you see these kind of photographs, you probably would kind of think, oh, this is the tall and thin person who has heart problems, and they said it was Marfan's. And actually, yes, quite a few individuals with Marfan's tend to be tall, tend to be quite thin with low muscle mass, tend to have chest abnormalities, long fingers and toes. They also have these unusual striae, quite high and arched palate, also present with lens dislocation. So they have eye problems in addition to heart problems. And because they have long fingers, we can demonstrate what is called wrist and thumb sign in them as well. These individuals have a young onset aortic dilatation, and therefore monitoring them, treating them appropriately, and actually thinking about prophylactic surgery would be important. And these are individuals with vascular EDS, and as you can see, there is a slight facial feature in these individuals, basically because of lack of connective tissue. So they have much more sharper features and tend to have a slightly more aged appearance as well. And individuals with this condition, it's a rare type of Ehlers-Danlos syndrome. It's not the common type, which is the hypermobility type. Often there's an increased risk of arterial and hollow organ ruptures. And therefore, identifying these individuals early would actually be really beneficial for them in terms of management as well. This is one of those conditions which is associated with a significant risk of fatal complications. So when we come to other TGF-beta genes, there have been a series of publications in the early 2000s identifying TGF-beta receptor 1 and receptor 2. Bart Lois described this group of conditions where individuals have craniofacial features, so head and face unusual features, along with some features which are slightly more suggestive of vascular EDS as well, with thin skin vessels being much more prominent and unusual scars as well. But some of the subtle features in this condition include early fusion of the skull bones causing craniosynostosis, as well as having a bifid uvula and quite significant hand and foot abnormalities as well. As they studied this group, they've also identified other TGF-beta genes that were involved, which caused a fairly similar but overlapping features with the initially described TGF-br 1 and 2 genes. And these individuals also have an increased risk of aortic problems. When we think about this group of TGF-beta receptor, TGF-beta genes, you can see that there are quite a few vessels that are involved, not just the aorta. And what's really interesting is that it's not just one vessel that's involved. Actually, more than one vessel can be involved. So you can find a person with an ascending aortic dilatation, but also having a carotid artery dilatation or a splenic artery dilatation as well. So it is important not just to look at the top bit of the aorta, but also to look at other vessels when you're considering imaging. So the next group of disorders, this is what we would probably describe as the non-syndromic or the familial thoracic aortic aneurysm and dissection genes. There are several genes which I've probably put all in one slide that have been described over a period of 5 to 6 years. And ACTA2 is probably the most significant in this group of genes, the smooth muscle cell contractile genes, because it accounts for quite a large number of familial thoracic aortic aneurysms. 16% can be associated with the misprint in this gene. And as you can see, again, there is a diverse vascular disease in this group of disorders, including quite premature coronary artery disease, as well as cerebral aneurysms as well. In addition, they have some unusual features. Not all of them have it, but iris flocculi, which is shown in the image there, as well as congenital heart disease, such as bicuspid aortic valve and PDA. MYH11 is another one of those genes, and MYLK and PRKAG1. All of these do not have any major unusual features associated with them, but they are familial aortopathies. The one thing that I probably highlighted here is the MYH11 gene is actually also noted to have a consequence when there is an increase in dosage or duplication of the whole gene in the recurrent copy number variant that I've outlined there, with a slightly increased risk of aortopathies, and this is being defined a little bit more. So if we come to the pathogenesis, whether it is the raised TGF-beta signaling, whether it is extracellular matrix remodeling, or whether it is disorganized smooth muscle cells, what we actually know is all of these can actually cause thoracic aortic aneurysm formation. So if we are thinking about someone who has a dilated aorta, they could have any of these genes. And there's quite a lot of overlap in the clinical features with these individuals. So then what we have to consider is genetic testing for them, isn't it? So why is genetic testing important? Because there is some gene-tailored management that is applicable. For example, in FBN1, we know that the in Marfan syndrome, the FBN1 gene is involved, and the surgical indication is we say the aortic dilatation before it reaches more than 50 millimeters. We should be considering surgery for them prophylactically so that we can prevent fatal consequences. And then treatment as well. Certain drugs have been considered, and there have been several large trials associated with it as well. Again, vascular EDS associated with COL3 is actually got quite a bad prognosis, even with surgery. But again, treatment with celiprolol has been recommended. Losartan has been trialed in some centers as well. Although the outcomes have not been conclusive, these are still being considered in big centers. In TGF-beta receptor 1 and 2 genes, we know that the intervention perhaps needs to be considered at an early age, and therefore, early diameter of the aorta at around 40 to 50 centimeters, rather than like Marfan's when it really needs when it's really at 50 millimeters. Again, treatment also includes both beta blockers and ARB. Whereas in HTAD, we don't have that much data. And this is the non-syndromic aortopathies that we are talking about. So the familial thoracic aortic aneurysm disease with associated with smooth muscle cell genes. So now we have mainstreaming of genetic testing. This can be requested by a cardiologist or a geneticist. And there are resources that are quite widely available. But how can we simplify this process for you? So what we first started off with is kind of looking at what the indications are. In GSTT, we do have GSTT-based guidelines for genetic testing. This is currently being reviewed. But as you can see, we've given a little bit more guidance on what we would include in clinical examination of the child as well as the aortic dimension measurements. We've also given a little bit more information with regards to considering not just aortic dilatations, but other arterial involvement as well. We've given a little bit more guidance regarding bicuspid aortic valves as well. And then there is a little bit more detailed guidance with regards to when to consider genetic testing for vascular EDS as well. Now, all of these guidelines are again based on what the National Genomic Test Directory actually does recommend. The main thing with the National Test Directory is that they give you age of onset specifically. So below 60 for aneurysms and dissection, and below 50 for aneurysm and dissection, below 60 if there is a first degree relative that's also known in the family. In addition to this, we also have this Genome app that we have actually developed within our region. And there is published content in the Genome app for clinicians to help them with a flow chart as to when genetic testing and referral would be appropriate as well. So the take-home messages from my bit of the talk today: young onset aortic disease, and I probably will say less than 50 or 60 years of age when there is no other risk factors associated for the onset of aortic disease. When there is more than one family member who's affected, then family history also becomes important. But we have to remember screening of family members is also necessary because there's variable penetrance and people will not feel unwell with this and therefore may not present to you, but you have to go looking for it. The other thing that I also wanted you to remember is aortopathy is not always associated with unusual features. We just have non-syndromic aortopathy where it is familial and there is an increased risk there as well. And then genetic testing is helpful, and we can offer this as a panel testing. There are clear guidelines as to when you should be considering genetic testing, and we are happy to help with that as well. So that's me, and I will stop.
Thank you very much, Leema, for a great overview of a complex subject. So a wonderful overview. I am going to move straight to Antonio. We're going to do questions at the end, if that's okay. And just a reminder to those listening to please pop your questions in the chat if you have any. Please don't feel frightened to ask a question. If you have one, our speakers, I'm sure, will be delighted to answer them. So moving on next to Dr. Antonio de Marvao, who is a cardiologist based at King's College Hospital and also has his academic work within King's College London. Antonio is going to speak to us about the use of AI to identify patients with their aortopathy who are suitable for genomic testing. So following on from the introduction Leema's kindly given us about genomic testing in these patient groups. So over to you, Antonio. Thank you very much.
And you can hear me and see the slides? Yeah.
We can, yes, thank
Perfect.
you.
All right. So today I would like to talk to you about some projects we have underway at King's Health Partners with the goal of using AI, both natural language processing, large language models, and other machine learning approaches to improve the care of patients with inherited cardiovascular conditions. So I'll just start broad because lots of the processes and the goals are very similar. So across inherited cardiovascular conditions, they have many features in common. They're individually relatively rare. They tend to be diagnosed by a combination of multimodal data. So as we saw, clinical examination, clinical features, but then a combination of ECG, imaging, echo, and ultrasound CT, and then genetic testing. Broadly speaking, they come under like three main buckets, which is the channelopathies like long QT, heart muscle disease, HCM and ECM, and the aortopathies that are the subject of today's talk. They also share, as we heard from Leema, that at early stages, they are asymptomatic. So very often we find patients and families following a first presentation that is catastrophic, such as sudden cardiac death or aortic dissection. We have data in our own region, for example, from the charity CRY that screens young, healthy people. And they've now screened around 300,000 adults, many in our region, and they've report finding potential life-threatening cardiac conditions about 1 in 300 patients, and in about 1 in 100 there are features that require further follow-up. We also know from population studies, so these are not patients, again, community-dwelling adults, that thoracic aortic aneurysms are relatively prevalent. About 1 in 600 people will have an asymptomatic unknown aneurysm, and that about 5.3 per 100,000 will dissect a year. Sorry, 1.6 per 100,000 dissect a year. On the NHS, we also come across this the situation that patients have the right tests, but in the wrong setting. So they come to A&E with their twisted ankle, they're having pre-op surgery, they're having a CT for COVID or lung screening. So they have the right tests, but for a different question. And sometimes those specific features that could indicate an inherited cardiac condition are not immediately recognized. It's particularly harder for when you're looking at a result of one condition to put it all together with their ECG and their family history, etc. It's very easy, as you all know from clinical practice, for patients to get lost to follow-up. And we know that genetic testing and family screening, although they're becoming more mainstream, is still rarely offered outside specialist care. When they do make it to specialist care, it's still difficult to know how many patients we have, how many are missing, which ones have had tests in their testing interval. And it is, again, hard to systematically identify patients that will be suitable for a new therapy, that are on a given drug, that might be suitable for a novel treatment study or genetic testing. Just this week, there's been a research letter in circulation really highlighting this. So this was data from the targeted lung health check, so patients undergoing low-dose CT to screen for lung cancer up in Hull. Over 3 years, they screened 10,000 people, and then they looked in this non-targeted CT, what was this incidence of thoracic aneurysms, and they report 1.3% of everyone, so 136 patients out of these 10,000 that had aortic dilatation, and then just in this short period, 7 were deemed who should have undergone aortic surgery, although only 5 of these were fit. So it's definitely a condition that is prevalent, and if we do the tests, we're picking up these changes if we look for it. There are also other issues in the NHS, mainly biases. Again, data from our own region in South London. This is data specific to TAVI, to aortic stenosis, but we're seeing it across all referrals to advanced care in that there are systemic biases with, for example, for TAVI, patients of white European background being 8 times more likely to be referred for advanced therapy. So there are systematic biases in our current care. So with this set of questions and goals, we went to NHS England about 18 months now. And we proposed that AI can improve identification, risk stratification, and clinical care in these patients, that we can use a combination of these tools to enable real-time recognition of these phenotypes, that we could use AI to integrate at scale, so hundreds of thousands of patients, structure their clinical records, their letters, their imaging, ECGs, genetic testing, and that all this information, if distilled in a much smaller format, would support clinical decision-making and clinical pathways. It would help overcome some of these human biases, and that we could potentially develop pathways where patients were fast-tracked to specialist care or directly to familial genetic testing, and using the same tools, identify patients for clinical trials, and use the data set for research, for genomic discovery, predictive modeling, and outcome forecasting. And we're very grateful to NHS England that helped us establish the Genomic AI network that funds some of the work, the pilot work I'll describe now. So as Leema pointed out, there are very clear guidance nationally for when to refer patients for genetic testing. In this case, the R125 gene panel for aortopathy. We know that knowing the genetics is also very important to predict outcome. So a different paper from the ones Leema showed, but again, very clearly highlighting that patients with syndromic disease, with Marfan and Loeys-Dietz, have many more events and at an earlier age. So knowing their genotype, even when aortic dissections have happened, is very helpful. It might also help predict what surgery the surgeons do. So here a smaller paper, but comparing Marfan's with Loeys-Dietz, where they suggest, given that the recurrence of aneurysms after surgery is so much higher in Loeys-Dietz, that more extensive aortic arch surgery might be indicated based on the genetic information. So what are we doing? So we're using a set of tools that were developed at King's Health Partners called CogStack. What CogStack does at its most simple stage is be a data warehouse. So it ingests all types of clinical data, be that ward round notes, clinical letters, echo reports, MRI reports, CTs, blood tests. About 80% of all clinical data is unstructured. So that means it's free text, it's not in neat little tables. Once we get all that data in the data warehouse, we can then start superimposing layers of artificial intelligence to help make a sense of it. Across King's Health Partners, we have about 8 million individual patients that have had some sort of contact with us. That could be just, an attendance to A&E or more extensive chronic care. We can then teach AI, so using a tool, for example, natural language processing, to read through the clinical text and to make sense of it, to structure it. So here I show an example of how that works and how we do this supervised training of the computer. So each of those little gray boxes on a clinical letter represent an individual predictive model. So you'll see that humans describe clinical terminology in different settings. So you could talk about heart failure, dilated cardiomyopathy, LV dysfunction, and lots of kind of ways of describing the same phenotype. And what we can teach the computer is to kind of understand and translate that data into more similar structured terminology, SNOMED or HPO. We could also teach the computer to understand if we're talking about the patient itself or relatives, if we're saying we're negating a diagnosis, so for example, does not have heart failure, if we're talking about differential or a confirmed diagnosis. And this is very useful to read millions and millions of documents. We could also then use CogStack or the tools that are part of this environment into cohorts, into dashboards. So we could make specific dashboards or lists of patients with given concepts and quickly have a look at their demographics, as a cohort, what medications they're on, what interventions, what was the last test they've had, are they still under follow-up or they've been discharged. So the 4 pilot conditions we're studying for this genomic AI network pilot are hypertrophic cardiomyopathy, aortopathies, familial hypercholesterolemia, and dilated cardiomyopathy, and each have different challenges and different data sets we're trying to explore. So I'll just show you some of the very early work on aneurysms and dissections. So this work was led by Dr. Alex Denk, who's one of our clinical genetics consultants. We trained a natural language model to understand all the concepts surrounding dissection of the thoracic aorta or aortic aneurysms. We then went through every single CT scan that was done at GSTT Trust in the last 5 years. We identified the ones that had mentioned to aortic dissection. We then compare those against the patients who have had genetic testing. And if they had not genetic testing, they would then qualify for our pilot. So we found over 3,000 patients with CTs mentioning aortic dissection, of which 242 were under the age of 50, as you saw, that is relevant for genetic testing referral, and then another 319 under the age of 60. For this particular pilot, because we're kind of limited in time and resource, we focused on the aortic dissection only. Aortic aneurysms would be a much, much higher number. And we're now bringing these patients directly to a one-stop clinical genetics clinic where they get assessed by a specialist and offered genetic testing and family screening there and then if the diagnosis is confirmed. So we're really at the beginning of this pilot, and especially in terms of getting the genetic results back. So of the first 4 patients, all were confirmed to meet the criteria for genetic testing and were sent for therefore genetic testing. One of the 4 has had a positive genetic Marfan diagnosis, and hopefully in a few months we'll be able to report more on this pilot. We can also once we have these lists of patients or these documents, start using other AI tools. So you've all heard now of ChatGPT, of large language models. So I show you there some preliminary work by Dr. Schweitzer, another PhD student in my group, where we asked the computer to read through, sorry, I'll just pause that, to read through a CT report that was done for, I believe here, lung nodules. And then we're looking for indications for genetic testing. So you'll see here the model is thinking, is going through the criteria for referral to genetic testing. So he has identified dilatation of the aorta and is now kind of going through all the information, as access to the diameter, the age, the family history, etc. And then we'll kind of suggest to the clinician whether genetic testing might be indicated or not. So you'll see on the right-hand column that genetic testing was indicated and why. And now here we're going through another one, 68-year-old with mild dilatation, so only 37 millimeters, some other risk factors such as hypertension. So this patient would not routinely be referred for genetic testing. So we're trying with these kind of tools to kind of systematize the referral. We also want to use AI to kind of facilitate referral to genetic testing. Here I show you a mock for a referral for clinical genetics for an HCM patient. So we kind of load 18 documents we have on records for this specific patient. We confirm that we're considering HCM, and then it kind of prepares a referral to clinical genetics, showing the indication for genetic testing, in this case, predictive genetic testing, indicating if the patient is symptomatic or not, if it has a phenotype or not. And finally, we're looking also in dynamic risk stratification, as I told you. I give you here an example of where we are with hypertrophic cardiomyopathy. Again, we're using AI to read through all the tests the patients are having all throughout the year, and recalculating their risk of sudden cardiac death as we go. So if they have a Holter, if they have an echo, if they report an episode of syncope, the computer will recalculate their chances of sudden death and highlight it to the responsible clinician to review the findings. Also relevant to aortic dissection, we have lots and lots of data in electronic health records that is very difficult to keep handle of. This is a different population, so I'm also interested in pregnancy, but from a study I'm doing where we're looking at 50,000 pregnancies at St. Thomas's over the last few years, we have about nearly 2 million blood pressure readings. And you can see how you can integrate all this data that is being calculated all the time to risk stratify the patients. For example, a patient with known aortic dissection, is their blood pressure well controlled or not? And finally, the final step that we want to do, and we haven't yet started, is really integrating all data at all time in a dynamic fashion across the electronic health records to see if we can improve risk stratification. For now, this is really at the beginning of a research project, but that's where hopefully we'll go over the next few years. So in conclusion, I hope I showed you that AI can be very useful to analyze and make sense of routinely acquired data. So this is not new data, it's data that is already there and just making the most out of it. It can enable systematic, rapid, at-scale, and hopefully unbiased, although we always have to check for that identification of and risk stratification of patients with ICC. This is a wonderful data set for research, for clinical care, for clinical trials. And these tools were all developed here across King's Health Partners. COGSAC is co-owned by all these health partners, and the project is supported by NHS England. Thank you very much.
Thank you, Antonio. Yes, someone's written incredible work in the chat, and you know it's fascinating and wonderful to hear more about the work you're doing and the work within the Genomic AI Network of Excellence. Again, you know, prompts to people, please do put questions in the chat. We will reconvene towards the end with some questions, but thank you. That was a wonderful talk. I would now like to introduce our third speaker, Professor Maite Tome, who is a consultant cardiologist based at St George's Hospital, Professor of Cardiology at St George's University of London. And Maite is kindly going to speak with us about aortic dilatation, sort of more broadly. When should we be referring patients? You know, we know it's a reasonably common condition. So when should we refer and when should we intervene? So with that, I will hand over to Maite. Thank you for joining us today, Maite. We can't quite hear you yet if you're there. We can see your slides. Can you hear us, Maite?
Apologies, I think that I was we
can hear you now though. So fantastic.
Are you seeing my screen, or what are you seeing at the moment?
We're seeing it, we're still seeing it, not in presenter mode yet. We've got the thumbnails down the side.
At the moment, are you seeing my screen already or not?
We can see the overview with the thumbnails as well. Not in presenter mode, but we can see your slides.
Okay, let me just get out of here because it seems that unfortunately today is not the day, you know.
There's no worries.
So has it changed or not yet?
Not yet.
Okay, fine. Stop sharing.
Oh, it might. Oh no. Okay.
Right. So let's do it again. Apologies for this. You should be seeing something now, otherwise I just carry on.
It's not in presenter mode, but we can see the slides, so feel free to carry on like that if that works for you. We can see them.
Okay. If they move, do they move? No. So apologies for all this. We tried before and it worked, but it doesn't want to work at the moment. So I'm just going to try one more time.
No problems. The joys of Teams.
I'm afraid. Yeah. Okay. And then. So you should be seeing my slides now in presenter mode. Is that the case?
See me at the moment, but maybe if you're sharing your window, perhaps
I am.
Bring the slides.
I am sharing the window. Okay.
We'll try one more time.
Apologies for this.
No worries.
Mm.
The other option would be to zip them across by email quickly, and we can see if we can share them for you at this side.
Okay. If you see, what are you seeing at the moment?
We can see them with the thumbnails down the side, just not in
Okay.
presenter mode.
I'm just gonna go for this because for whatever reason the presenter mode doesn't want to click in, so it does all right for everyone. Okay.
Yeah, absolutely. Do you want to try advancing them and just check that they're moving forwards?
Yeah, they will. I would just go through this.
That's it. Yeah, that's perfect.
I would just click them. Okay, so sorry for this. So now we start again. So thank you, Rachel, for inviting me to talk about today in this fantastic webinar on inherited aortopathy. So my colleagues have already introduced the things and have done most of the work that I needed to get a little bit to practical questions about when to refer and when to intervene in aortic dilatations. So aortopathies is the broad name that we use for diseases of the aorta that predispose it to an increased susceptibility to dilatation or dissection. We have for many years, we use a very broad way of classifying them into inherited or non-inherited conditions. And as you can see, life always is more complicated. Over the last 20-25 years, there is a huge effort to try to understand the aorta as an organ. So even though most of the talk will be referring to the thoracic aorta, it is a reminder that this is the largest artery in the body. That is what is a connected conduit. In reality, it has got a wall that is alive and is actually critical for all the sensors that are going to be structurally important for the secretion of the elastic fibers and the combination of all what the aorta should be doing, which is basically stretching and recoiling. The proximal aorta probably is, we should define a biomechanical wonder because it withstands high pressure and wall stress and more than 30 million pressure cycles a year. So why the thoracic aorta and how big is the problem? For thoracic aortic aneurysms occur in 5 to 10% persons a year, but when I tell 100,000 persons a year, but when I say that, it doesn't really kick home. So when I actually mention the aortic dissection kill more people a year than road traffic accident, probably that's when we all understand that this is important. Aortic dissection is associated, with very high risk of mortality, and if you successfully get to the right center in the right time, still you might be suffering with high risk of comorbidities lifelong. So in reality, the treatment is prevention, and this so far is elective surgery. So therefore, the next problem is the recognition of the patients presenting with either aortic or chronic aortic syndromes. And you will say that everyone will be able to diagnose an aortic acute syndrome. However, the charity and the patients are sticking and plastering or any departments with signs like this. I'm sure you're all familiar, to let us know that you need to think aorta to diagnose it, which is very important because otherwise a lot of life still could be missed. Well, diseases of the aorta, the acute syndromes might make the limelight, and a lot of the surgical techniques and symposiums might be delayed, that they might be tailored to see what could be the solutions when something has broken. In reality, the aorta disease is a chronic disease, and therefore is a silent killer. But on the flip of this, the most important part is that the aorta, it is a huge opportunity for prevention. So therefore, this is what we should be more worried about. If we look about guidelines and how we want to do better, where to look for information, in reality, there has been a shift on the message. And since 2022, with the publication of the American guidelines, there actually is a humbleness coming around that what it was before, simple. You see, if the aorta gets a little bit big enough, let's change it. It's probably a little bit more complicated. So we need to focus on the right team for the right patients, the right surveillance imaging, recertification beyond the aortic size, and actually so we can identify who need, when they need an intervention, and where this intervention need to be best placed. So, so you just take one thing from me today. This is about who, when, and where, the 3 W's, and the best treatment is going to be always prevention. So you will imagine that this is easy, this slide is going to play funny, so I just will try to animate it because we are in a screen that this is not going to show as I want it, but anyway, just take it with me. We have since 2022 more than 5 different guidelines that they have been published in relation to even the European guidelines, the children consensus, the surgical guidelines, and different parts. So reflecting that there is a lot of emphasis on putting together a lot of information, but also a lot of humbleness that there's still a lot of work to do. And is the natural history of the aortic disease depend broadly on the location and the cause. And the causes, you see them there, a lot of hereditary conditions, degenerative conditions, as Leema said, whether a patient has had previous dissection. But in reality, if we want to do a screening process like, Antonio was talking about, which are more frequent. So aneurysms of the root and ascending aorta, they will be the most common, 60%, following by the 30% of the descending, and then the arch, and we're talking about thoracic aortic disease. So how we identified the patients that might be having aortopathy, and what do we need to know? Well, the size of a given segment is dependent on the sex, the age, the height, and to a certain extent the body size. And the risk factors, majority, particularly with age, it's going to be hypertensive disease. The European guidelines are majority tailored to explain how bad atherosclerosis and hypertension are. And you talk about atherosclerosis, you're talking about cholesterol, smoking. But also very important to note that you're one of those who are harboring one of the genetic variants that Leema was talking about. You also have a genetic predisposition to actually act different through life and have higher risk of dissection. So what is normal in our aorta? So, we could say that anyone who has a aortic size, which is more than 2 standard deviation in any of the segments, and think about it, that the aorta gets thinner as it goes down, it will have is a potential candidate for a degree of aortic dilatation, even though for themselves could be normal. Clinically, you need to be a little bit more practical, so you recognize numbers. Roughly speaking, 44 males in the root and 34, 36 for females, although it's better to individualize. We are talking about dimensions, and it's important that we leave, particularly when we're talking about the thoracic aortic, we leave alone the concept of aneurysms, because in reality that works very well for the distal aorta and smaller arteries, where an aneurysm clearly is 1.5 times bigger than the predicted size of the vessels. But however, if you think about this for the thoracic aorta, it doesn't work very well, because we will be operating aortas which are not even aneurysmatic, and it can become quite complicated. So what sort of number to use to confidently talk about aneurysms? So guidelines are proposing something about 4.5, and this is based on large populational data where you have a hinge point of relative risk that increase, when you go over 4.5 threshold. And this is obviously no absolute risk. This is risk related compared to others. So does it matter to have a big aorta or not? Because, there are a lot of determinants. So tall people are allowed to have a little bigger aorta. Shorter people, the aorta has to be in keeping with the size. And also it depends how you measure and where you measure. You have a little bit variations, and therefore there are a lot of recommendations about what is normal or abnormal. But in reality, clinically, it's more important why is that important? So it might be because of cutoffs value for surgery. It might be because, depending on the etiology, it has got a huge different significance, or might be important because your patient is pregnant or wants to drive a lorry or a plane, or actually want to compete in a very highly athletic manner. So we need to, agree that even minor differences might be very important. So we need to start measuring the aorta in a very systematic manner. And regardless what guidelines you follow, you have to understand that you need to follow them consistently and repeatedly. So I'm gonna keep my opinion how much agree or disagree with all the variations and different advice that they might cover, some of them better or not, ethnicity, but it seems very reasonable what the European guidelines sort of advise, which there is a gradient with age, there is an upper limit of normal, which guide you a little bit to know where your patient is falling. And also, if you measure at the end of the diastole and you do leading edge, you have a better concordance. But if your team doesn't do that, then of course you don't have to worry too much about it. Just do exactly the same thing all the time, and that will be a lot easier. I'm gonna have to take this away because otherwise we are not gonna see anything about this. Okay, this slide. Right, so we want to use this for screening. What we're going to be able to do. So echo might be very useful for screening, but obviously unless you're seeing good part of the ascending aorta, you're probably going to miss ascending aorta disease, particularly it's a little bit distal ascending, and therefore you want for a diagnostic test, whether it was incidental, as Antonio was telling us, or not, you need to do it with also looking for a CT or MRI, depending on your team. And therefore, the recommendations is then when you find abnormalities in one side of the aorta, go for the rest, go and look whether the rest of the aorta has got a disease or not, so you can choose what you're going to be looking in the rest of the, for the rest of this patient surveillance period. We said before that we need to recognize the individuals at risk. So this might be easier when they have a syndromic aortopathy, because the appearance might actually highlight what could be the problem, and we might actually be at risk. And these are features that visually are easy to recognize, and it might be associated with aortic dilatation, and identification with genetic testing actually has got a very high yield in those individuals. However, cases like this, which are very frequent, and we might be seeing them every day in clinic, a gentleman who has got previous atrial fibrillation and who has been seen by a cardiologist, which is not specialized in aorta, has treated the aortic dilatation and has decided that because it was big, so aortic root of 45 at the age of 50, that I needed to see this patient as well. So I do what I do for a living. So I did a family tree, and looking for the family tree, basically I ended finding out that his father's all siblings had all died with aortic dissection, all of them with hemipericardium. And then when I started screening the family members, one of his brother also had aortic dilatation and also starting to have a hematoma distal to the left subclavian artery. And that was the hint. This was the only finding that made me look in the rest of the family and else. So, what do you think? This is luck, is it common? What do we know? How do we treat them? What do we do with them? Because this is, this is the non-syndromic thoracic aortic disease that has been described by many of the colleagues before, and is responsible for 20% of the cases with hereditary thoracic aortic disease. So you would think, yeah, it doesn't matter. Family history doesn't matter. Has anyone else than the centers that look after aortic disease have found this before? Yeah, it does matter. So you see, for example, these populational studies in very different parts of the world. So we can see in Taiwan, and we can see the Danish study, just the fact that a family member has presented with aortic dissection conferred a risk of first-degree relatives. One is corrected, even the Danish study, by patients with Marvao and hypertension. So not surprisingly, a very cheap tool that has come now for the guidelines and is a type 1 indication is for, in order to identify your family members, you need to do a family tree. And you better, collect, family history of dissection, the dimensions, and any other problems. And why is that? We know Leema has told us all about it. It's just the hereditary thoracic aortic disease is heterogeneous, so there are a lot of genes, but also even with the worst phenotype, there is a spectrum of a disease, and we are learning all about it. So we are learning in a way that those patients that we identify well, and you can see Marvao on the top of the screen, blue is that elective surgery and black is when they die. So we have very little death for those who are well identified, and even less in the bicuspid because we go and operate them all very early. But in the non-syndromic hereditary thoracic aortic disease that we are a little bit of rubbish identifying them, we then operate them late, right? So this is a dissection surgery, or they die. So we are not doing very well yet on that. And also, why are not doing that? Because they don't have the same risk, so certain patients had got a much, much higher risk, and therefore the idea of doing genetic testing and identifying them through that has penetrated the guidelines, Americans or European guidelines. So let's go through this, which is really practical. You can see that 60, is going to become 70 soon, but anyway, let's go with 60 and a patient who has got significant aortic dilatation. These guidelines, they go a little bit shy, so we don't get overwhelmed with all sort of referrals, and they put a set score at least of 3. So at least we have significant aortic dilatation before we start looking for all sort of family members referrals. But basically, this is hypertension, and hypertension is no binary. Hypertension is significant enough, to be responsible for a degree of aortic dilatation. So you're looking for, an aorta of 4.1 in someone which is, 59 years old and he's on 3 drugs of hypertension, to be honest. Unless it's something else, I'm not going to get very excited. But if you have, very low doses of ramipril and you have a bigger aorta, perhaps hypertension is not so easy to dichotomize. But in any case, if you have features that you can identify and you have history of dissection, we want to see those patients and we want to help you about. So in the last few minutes I have, I'm just going to go through the idea of who needs to be operated. Then this is the story of, why we are operating people nevertheless, and this is the story of the size. So there are, many, many years of guidelines based on just diameters. The bicuspid aortic groups, they separated from this, and they actually decided to lower the cutoff points long time ago. And then information for registries like this one, the IRAD realized that you are actually operating people by guidelines. A large group of patients who are has dissected in lower diameter, so you're missing a lot of them. So recertification, size only or orientated is poor. So we need to put more recertification items in there. So the guidelines are rich now on that. So they're penetrating this. So they want us to index to height. They want us to have in contact, to take into account the rate of diameter growth. We are more worried if the patient has got root type dilatation, and then we are taking into account age. As Leema told us, that is very different to have dilatation when you are very young, very highly suspicious, that are later on in life with many other these factors, even via a spectrum of disease. So the guidelines are all about, when to operate them. I think I have 1 more minute, Rachel. Can I? Or yeah, I carry on.
That's fine. Yep, carry on.
Okay, so the guidelines are about how good our surgeons have become. So in 10 years from the 2014 to, the guidelines to 2024 publication, what mainly have changed is that the operative risk has gone down and the imaging technique has got better. So as a result of that, patients can be operated providing that the risk profile fit, and we identified those at risk a lot earlier. So that's actually what has happened, that we will follow those who are stable. We will start identifying risk factors, which are rapid progression, the the indexed values, as well as family history or genetic factors, but we will attend to other things which are like root phenotype, and we might be able to offer surgery at the same level as that we will offer surgery for patients that the bicuspid aortic valve, although depends on the surgical result of your center. And we're going to stop offering all the same for those who have gene identified, so Marfan, in most teaching centers will be getting very nervous anytime for 4.5 particular risk factors, and you have good results. We might operate them earlier, whether depending on other centers, they might operate it when they get to 50. But if you have higher risk genes, you will act accordingly, and you will try to tailor this to your family and this. So this is the first time, according to the Europeans and the American guidelines, that we're starting to put variants into when we're going to make aortic dissection. So this will change quite a lot. But again, I think it's important to note that it is important to take into account genetic testing. So just almost finishing. So the basis of cardiovascular management of our patients is the recognition, the surveillance. Medical management give us a small opportunity perhaps to delay matters, but in reality, the idea is that if the surgery is better, is to get them in the right hands when we can do the best for them. And in the meantime, what do? Was treating risk factors. Remember your blood pressure limits to normal tension and your cholesterol as low as you can. And with this is the end of my presentation. So just remember who, when, and where, and recognize those individuals at risk. And thank you very much for having me today.
Thank you, Maite. That was excellent and a really great sort of walk through those guidelines. We had a few questions in the chat that I think have been answered as we've been working our way through, and appreciating it's just after 2. If people have further questions, please do reach out. We can direct those on to the speakers. I will wrap up there, but just thank you so much to all 3 of our speakers, to Leema, to Antonio, to Maite. I think you've given us a really great overview and lots of detail around inherited aortic conditions, which I personally struggle with, and it's been an excellent session. I've learned lots, so thank you so much to all of you. Thanks to everybody for listening and joining us today, and I hope we'll be back with some more of these sessions later in the year. Thanks, everyone. Bye-bye.